So give me 1 second just to read the acknowledgement. Founded in 1899, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia, the original peoples of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We greatly recognize our history. Okay, thank you for that moment. So today I'd like to first and foremost welcome everybody to our first convening. Today we're going to be highlighting and centering cultural humility and Native Americans and health or broadly. So today our goal is to really get a better understanding of our local Native American community and the health topics and health adjacent topics which are most important to the lives of our Native American population in New Mexico, and I'll say the greater US as well when generalizable. So we have an esteemed speaker, Mr. Norman Coyote, who's going to be speaking with us today. But before we get into that, I will first like to acknowledge and thank the staff for this committee who's done a lot of work behind the scenes. It's been a lot to put this together, so I'd like to just take a moment to say thank you to everyone who's helped out. We have an amazing staff that's here. Let me also introduce myself as well. Verlin Joseph, I am the committee chair. I am interested in all things related to epidemiology. My research centers substance use, criminal justice, and criminal justice outcomes as well. So trying to understand how we can use different interventions to both improve treatment outcomes for substance use, as well as reduce outcomes related to substance use and criminology around recidivism, et cetera. So I'm always happy to talk about that work and to invite collaborations as well, especially cross-cultural collaboration so that we can understand what's going on at the greater New Mexico and not just among specific sort of granular populations. So I'm really happy to be here to talk to you all today and to learn more again about what we're doing as a community and as a college. So first, I will like to introduce our dean, our associate dean, excuse me, Dean Andrus. So Dr. Andrus is the associate dean. She's an associate professor at COPH. She's assisted us in arranging these convenings. Dean Andrus, excuse me, serves as an ex officio member of our DEIA committee and is also the college representative on the Health Science Center Inclusive Excellence Council. The HSC Inclusive Excellence Council informs and advises the Vice President of DEI and the Executive Vice President for Health Sciences on issues related to diversity, equity, and inclusion. Dean Andrus, would you like to say any opening words?
Thank you, Dr. Joseph. I'm really glad to be here with everyone and looking forward to this event.
Thank you. And so today, the next person I'll introduce is Dr. Khan, who will introduce our speaker. Dr. Khan is Navajo, originally from Mariano Lake in New Mexico. She's an assistant professor at the College of Population Health based here in Albuquerque. She has worked on community-based participatory research projects with urban and rural Native American communities and teaches courses in the areas of health services and policy, mental health promotion, and maternal and child health. Oh, there she is. Dr. Khan, do you mind introducing our speaker?
Yes. Hi, everyone. I'm very happy to be here today and to introduce our guest presenter.
Oh, sorry. Dr. Khan, do you mind telling us a little bit more about Norman?
Oh, yes. Sorry. I thought you were going to introduce the rest of the team.
Oh, sorry. You know, I'll do that as well and highlight everybody individually. So I'll start with, because we do have a really amazing staff. So our really sort of our co-chair, Alexis O'Donnell, who's done a lot of work behind the scenes. Alexis, do you want to say hi?
Hi, I'm Lexi O'Donnell. I'm an assistant professor in the College of Population Health, and I'm really excited to be here today. Thanks.
Okay, next, I'm not going in any specific order. Grace Chung.
Hello, I'm Grace. I'm also assistant professor in the College of Population Health, and um, very happy, very honored to be involved in organizing the convenings and happy to be here today.
And Dr. Dukes.
Thank you. Hi, I'm Dr. Amber Dukes. I'm the Senior Program Manager for the New Mexico Center for Health Policy, and I am the Secretary for this committee.
Okay, and we have quite a few other members, but right now, for the sake of time, I'll stick to some of our internal members, who are part of we have additional subcommittees within the DIA work, but I also would just like to acknowledge several of the other members of the DIA committee who have made several contributions to both this convening and the upcoming convenings as well. So thank you for your time. Dr. Khan, I'll turn it over to you.
Okay, thank you. Thank you so much, Verlin. So good afternoon, everyone. It is my pleasure to introduce our honored guest presenter, Mr. Norman Coyote. He is the Tribal Relations Liaison for the Center for Native American Health with the University of New Mexico, and he also serves as a co-director for the Indigenous Public Health Institute and a lecturer for the Department of Family and Community Medicine. Mr. Coyote is the former governor of Zuni Pueblo. He is a respected tribal leader, educator, and mentor. His experiences in health equity and policy position him to address cultural protocols, historical proprieties, and language sensitivities in tribal academic relationships. He uses his experiences and skills to promote cultural humility among healthcare professionals. He is also the founder of the Center for Native American Health's Tribal Leadership Public Health Symposium, and he has a background in Native American Studies and Community and Regional Planning. Please join me in welcoming Mr. Norman Coyote. And we can turn it over to you. Thank you so much for joining us today.
Thank you, Dr. Khan and Dr. Joseph and Dr. Andres and the rest of your COPH team. I'm honored to be requested to be the inaugural speaker for your convening for this year. And I'm also honored to be in the company of a lot of individuals who have contributed to my life's journeys education here at UNM, as well as in all the different aspects where we have worked together. And so I thank you. To begin with, Keshe Koton Sunna Kenawe, Norman Kuyatilishin, Otona Kotan Mula Pichik Mawan Chatler. Look at Laki Yaton Yam Kos Kowi, O Yanikotikona, Kos Yam Hoi Illi Aton, and Kos Antemus, and Kos Yanakunan, and Kos Samakui Kokshik Taton Nakehon, Iyashu, Ni will Awa Tunana, Usanakeho, Don Awa Shugan. In my language, which is Zuni, where I grew up for a majority of my time, and then I got placed into the Mormon placement program and grew up in Salt Lake City. And then after I graduated, I came back to the reservation to try and reintegrate myself into my community. I can tell you there are struggles for people who venture away for various reasons and try to come back home. Some of the challenges that are there, sometimes it's the community who don't want to accept the changes that you bring back. And so it's been, I would say, a struggle, but then it's also been an opportunity for me to use my newfound vision and perspective to try to elevate the next day for my people in comparison to the day that we're at now. In my language, I said, my name is Norman Coyote, my given English name. My Zuni name translated from Nak Kohana means white deer. I come from the Turkey clan, so any relatives out there who are from the Turkey clan, I welcome you. And then on my dad's side, I'm the Dogwood McCall clan. And I just said, for what I've learned in my short journey in my life, that I've gained to ensure that every individual's well-being, their their health, their spirituality, and their outlook on life. I hope that today gives me that opportunity to share a little bit of what I've learned with all of you. So I know I've been asked to come up with a PowerPoint presentation. Can people see this? Or,
Yes, we can. Thank you.
okay, let me just, now, can you see it or do you see my notes?
It's in presenter mode.
It's in presenter mode? So you
Yes,
can-
sir.
Okay,
We
So you-
we can see where your notes go though.
okay, so maybe I need to, oh, how do I?
You should be able to swap your displays.
Okay, let's see if I can. Nope, still not.
Actually, that's just the next slide.
This is the next slide, right? You can see my
Yes.
arrow?
Yes.
Okay, I want to get rid of that. How do I?
If you go to
Um,
display settings on the over the left where it's next to show taskbar.
Yeah,
Okay, if you like the one to the right where it says display settings. And then swap.
swap. There you go.
Okay.
Thank you
Thank
so
you.
much. You can tell I'm not tech savvy. So this is the title of my presentation, Engaging Native Americans in Clinical Care and Research Through Cultural Humility. You know, the title where it says Native Americans really has been debated because through various generations, that in itself has changed from our relationships with the federal government where we were received as American Indians, Alaska Natives through the various treaties. And then at some point it came to be American Indians only, and then Native Americans. And now the new generations like to use Indigenous. For purposes of this presentation, I interchange American Indians and Alaska Natives as is the federal identity that we carry based on the relationships we have with the federal government to sometimes the acceptable term, which is Native Americans. I also want to disclose that I don't speak on behalf of all American Indians and Alaska Natives. The native populations here in New Mexico and Arizona, particularly the Southwest, are very diverse. Although there's 20 pueblos in New Mexico and Texas, they're all unique, sovereign, self-governing pueblos themselves, just as the 3 Apache nations are here in New Mexico. So we don't really consider them to be one collective group of people, including the larger Navajo Nation, where there are various chapter houses, and each chapter house is unique in its own way and its own historical aspect. So my goal here is to promote health equity and healthcare engagement and healing through cultural humility. Objectives is just to describe some of the historical and cultural characteristics of the Native American populations, particularly in the United States and New Mexico, and to kind of think about some of the barriers that they face when they're trying to access healthcare. And then maybe lastly, just to offer some strategies of using cultural humility in creating cross-cultural healthcare and in research settings too. So if you're not aware, this is something that was developed back in 1976 by Edward T. Hall called the cultural iceberg theory, where if you look at an iceberg, there's only a certain portion that is visible, and the remainder of it is below the waterline. You know, the visual part of the iceberg represents just a fraction of the whole. It's kind of similar to culture, which is often perceived through observable traits like food, dance, rituals, language, and sometimes the clothing that we wear. However, these are merely surface manifestations of deeper cultural components like attitudes and values. Beneath the waterline lie a cultural culture's core values, learned ideas about what's good and bad, right and wrong, while different cultural groups may share similar core values like honesty or respect. Interpretations vary across situations, shaping specific attitudes in our individual daily lives. These eternal forces manifest as observable behaviors such as language, actions, laws, or communication styles. Importantly, a culture's core values don't change easily. They persist across generations through influential institutes. These institutions, powerful forces that guide and teach, remain resistant and amid external changes, shaping culture as they were in the past. So, So as we move forward, I just want to ask the question, what is culture? Well, here's one definition that I found most appropriate, and it's from the National Healthcare for the Homeless Council. It says culture is a set of learned beliefs, traditions, principles, and guides for individuals and collective behaviors that members of a particular group commonly share with each other. And it also includes those that are listed below: traditionally, ecologically, environmental knowledge, and so forth. And one of the things that I have to say is that each one of us on our daily basis move throughout different cultures, often without us knowing about it. When I woke up this morning, I was in the culture of my family, where there's certain values and beliefs and behaviors that are accepted within my family setting. And as I drove to work, I'm in a different culture, of a commuter, and there's certain rules and principles that I have to abide by to ensure that I arrive safely from my home to work. And then when I'm at work, there's a different kind of culture here too, because there's certain behaviors and principles and practices and values that I have to abide by when I'm at work. And when I was still at UNM going to school, that's another culture that I had to deal with. And then if I am fortunate to go back home on the weekend, I end up in a different cultural environment. So we can't begin to understand an individual's cultural makeup or the contents of that individual without knowing the different cultures that they sort of transition within in a given day or within their life's journey. And is being aware and reflective also about our own background and our own situations, understanding that we too also transcend through different cultures in our daily lives. So there's this thing that I've been able to find, which helps me understand the different continuums of cultural intentions, or what I call cultural knowledge. It's a gradation from where culture can be seen as destructive. And I think if you understand the historical nature of American Indians and Alaska Native, when the first contact was made and henceforth the federal policy was to destroy the cultures of those that were present here in what we now call North America, particularly the United States. And it was also to incapacitate a lot of the cultural practices and beliefs that were there. One of the things that the Southwestern experience was the domination of the Spanish Empire that came here, and the Catholic faith that came with it, which tried to not only destroy, but to incapacitate the religious practices of the Pueblo people. And so as you move up, there's different aspects of cultural intentions, cultural blindness, of course, and cultural awareness, which is developing a sensitivity and understanding, and it involves internal changes in terms of attitudes and values when you get up to here. There's an openness and flexibility of how people develop relationships within this cultural awareness. But cultural awareness must be supplemented by cultural knowledge. You have to know at least some aspect of the individual that you're becoming aware of their cultural aspects, their cultural being. The next step above that is cultural sensitivity. It's beginning to understand that there are cultural differences and similarities between you and other individuals that you interact with, without assigning values and without assigning judgment. But the ones that I really want to sort of concentrate a little bit on is the next three: cultural competence, cultural proficiency, and cultural humility. Now, this is where you begin to have a little bit more of a positive relationship, beginning to open those lines of communication that benefits both parties. And so the first one, taking a look at this, just defined by the U.S. Department of Health and Human Services Office of Minority Health. It says it's cultural and linguistic competence is a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. And the place that we work here at UNM, this is us. How do we become cultural competent? So cultural competency is a tool for leveling imbalances between patient and provider power dynamics. As the definition says, it's a congruent set of behaviors, attitudes, and policies. It emphasizes the idea of effectively operating in different cultural contexts. Knowledge and sensitivity and awareness do not include this concept. So it's a greater step above the cultural continuum. The shortcomings of this practice is the frequently used competency measures from one racial group as representing the norm. So in a healthcare setting, sometimes some of the health measurements that we use that was built on the general population are used in the minority racial and ethnic groups, and sometimes those measurements don't fit quite well, for those particularly set of racial minority ethnic groups, because they didn't contribute to those different representative norms that were created from the majority. So then one of the things that we have to do is, how do we ensure that the minority racial and ethnic groups contribute to a new set of measurements that include them, so that they are not seen as being incompetent because those majority measurements didn't include them at all. So in short, cultural competency is to learn about the other person's culture rather than to reflect on your own background, including the measurements that we use. It's sort of leads us to the next part, which is cultural proficiency. Now, cultural proficiency is also kind of like cultural competency in the patient-provider relationship. And it refers to the ability of the healthcare professionals to effectively engage and provide care to individuals from diverse cultural backgrounds. It involves an understanding, respecting, and integrating the cultural values, beliefs, and practices of patients into the healthcare process. And so with the definition here, which is from some of the authors, Nuri Robbins, Lindsay, and Terrell, from their culturally proficient instruction, the robinsongroups.org. Their definition says cultural proficiency is a policy and practice in an organization, or it's the values and behavior of an individual that enables the person or institution to engage effectively with people. It's also a lens for examining one's work and one's relationship. So it's greater than cultural competency. And some of the key aspects of cultural proficiency, which is different than cultural competency, is having not only cultural awareness, cultural sensitivity, but having communication skills. Effective communication skills is very crucial in a provider-patient relationship. Cultural proficiency involves adapting communication styles to meet the needs of diverse patients, including using interpreters when necessary. And sometimes communication might not be efficient if it's in the verbal style. A lot of American Indians, Alaska Natives are visual people. So if there's a way to include visual media in terms of communication, that could be an advantage to creating positive relationships. Another key aspect to cultural proficiency is a patient-centered care that emphasizes patient-centered care where health care decisions are made collaboratively with the patient, taking into account their cultural preferences, values, and priorities. And what this means is, I use my Pueblo as an example where a lot of our Zuni people still have trust in the traditional healers. And as such, they would like to actually have some traditional healing practices be incorporated as part of their Western care. And sometimes they would like to have the traditional healer come in first to do their ceremonies before any Western modality is engaged. So it might include something as simple as, a traditional healer coming in to maybe press somebody who might have a potential sprain on their ankle, or who might have, some stomach ailments, and the traditional healer comes in and does what we call laying of hands on the area that is impacted. Or it could also include the burning of various herbs and other plant products that are there. So it's just being adaptable to allowing, the individual's cultural preferences to be part of the Western treatment. Another key element is respect for diversity. Recognizing that, your patient might hold different beliefs and practices that influence their health-seeking behavior. again, I use my Pueblo as an example here, where somebody might belong to a certain Kiva group, which is one of our ceremonial dancing groups, where maybe a practitioner would like for them to partake of certain medication, but in their cultural setting in a Kiva, they're restricted to maybe take anything by mouth for a certain period of time. So how do you get that individual to take any oral meds? Or maybe they're part of a medicine society that requires them to be absent from home and be confined to one of their kivas. But, you know, the Western practitioners would like to see them on a regular basis away from their pueblo. So how does that person continue their traditional practices while trying to abide by, you know, the Western requirements of keeping your appointments? So it's just being diverse to know that, you know, the patient's beliefs and practices might influence when and where they seek healthcare and services. The last thing, one last key component of cultural proficiency is adaptability. It's being able to be adaptable and flexible in providing care, which may include tailoring treatment plans to align with the cultural preferences and considering alternative approaches to respect cultural norms. Maybe they live a distance from, you know, a health facility, and it's difficult for them to come in on a frequent basis. Is there a way that appointments could be made in sort of a middle place so that the provider meets the patient halfway? Or is it that somebody else other than the provider could come out to the individual's home base to provide care and treatment, or just to evaluate? So it's just learning how to be adaptable. So the next thing that I really have been involved a lot with here is cultural humility. And this is not something that I just decided to pick up. I am happy that Dawn Begay from the city of Albuquerque is part of the audience, because there was an incident that happened here in Albuquerque where several Navajo men left their home base and came to Albuquerque to seek opportunities. And unfortunately, one of those opportunities was not being able to find a shelter. And so they were shelterless, and they got attacked by some teenagers, and a couple of those Navajo men died. From that incident, the Albuquerque Family and Children's Services, the director, came to CINA to say, is there something that you as a Center for Native American Health could create or engage with our department so that we could create greater understanding amongst the different groups of people that, you know, are our clientele? And so working with First Nations Community Health Source, where Dawn was, and the Department of Family and Children's Services of Albuquerque, we created this cultural humility training. And we trained about 500 of the Albuquerque's Family and Children's Department employees about cultural humility. And then the managed care organizations found out about it, so we trained about 1,000 of their community health workers about cultural humility. And so this has sort of been the basis of what I've been able to teach and expand upon that. And so this is the definition that I found most appropriate, which the National Institute of Health used to define. It's a lifelong process of reflection and self-critique, where individuals not only learn about their own culture, but they start with an examination of their own cultural beliefs and cultural identities to create long-lasting relationship and engagement with other individuals that they come in contact with on a daily basis. So it's a term that was coined back in 1998 by two individuals, Melanie Trevelyan and Jan Marie Garcia. And what they wanted to do was they wanted to create a tool to educate physicians to work culturally, ethnically, and racially diverse populations. And cultural humility is different from cultural competency and cultural proficiency. In cultural competency, the goal is to learn about the other person's culture rather than to reflect on your own background and relationships to other culture. In cultural proficiency, all those key elements that I talked about are necessary for one to be proficient. Cultural awareness, cultural knowledge, cultural sensitivity, communication skills, patient-centered care, respect for diversity, and adaptability. So there's a whole host of key elements within cultural proficiency. But cultural humility really is, in a way, something that was created by my colleague in this visual diagram, Dr. Charity Bishop, when I was fortunate to be asked to help her create this Indigenous patient-provider relationship toolkit that she used as part of the School of Medicine curriculum. And so it's a look at how there's a commitment to a lifelong learning. I'm still learning, 60 plus years, I'm still learning. I'm always a student. I am a teacher also, but my passion is to learn as much as I can from the interactions that I engage with in my life's journey. And then I do a lot of self-reflection and critique. I analyze my assumptions and my biases. Sometimes my biases just involuntarily come out in my thoughts when I have interactions, and I have to evaluate, where did that come from? Why did it come out? It's also to realize that no culture is better than another. And sometimes I might not know, even within my interactions with other pueblos, the uniqueness of each individual sovereign pueblo. I'm not aware of a lot of their cultural values, beliefs, and practices. So when it's most appropriate and the time is right with the right individual, I ask to learn. I don't become intrusive, but there's a moment in time where you're given that opportunity to ask that question to learn more. It's also to embrace and learn similarities and differences. If you close your eyes and you hear my voice and you don't know who I am, you can tell that I'm human because I'm speaking the same language that all of you are able to understand. It's the same as I've heard other people say, well, you cut yourself and I cut myself, we bleed the same. So in a way, there are similarities that we carry. We all walk on 2 feet unless we have challenges, and we depend on different modes to be mobile, or sometimes we have gifts that makes us different. My sister-in-law's son is gifted. He's autistic. He's different in the way that he communicates to the way that I communicate with other people, but the similarity that we have is that we both enjoy Spider-Man. So our interactions sometimes is crazy, but we base it off of Spider-Man and all of the various characters that go within the world of Spider-Man. The other two is just an interactive approach, being opening to learning, asking questions when appropriate, and then understanding, and also answering questions of yourself to those that are asking you questions in return. Be honest and be open about what you share, but also understand that sometimes we can't share a lot of what we know, particularly for me as a Pueblo man from Zuni, although I belong to the Kiva group, I can't share a lot of what goes in my Kiva setting. And it's also understanding that there's a recognition of power, privilege, imbalances. We might not be aware of that, but sometimes our patients sort of through visual understanding, they recognize the imbalances, especially in a healthcare setting where the elderly see an individual come in with a white coat and they sort of draw back within themselves. And it's not because of the person, but it's because of what they're wearing. Maybe they've had family, or maybe they had communal history about the white coat. And a lot of it is generational trauma, a lot of it is historical trauma. And so those things we need to be cognizant about, that those things that are recognizable by people we care for can create power and privilege imbalances. Are there any questions up to this point? I hate to keep muttering. If anybody has questions, I really don't mind stopping to answer them, if somebody will just let me know. And then, so how do we engage, particularly the populations that are here in New Mexico, the Pueblos, the Navajos, and the Apaches? Well, I've been fortunate to have listened to my colleague, former Governor Regis Pecos, who's the co-founder of the Santa Fe Indian School Leadership Institute, who shared this multiple times. For the Pueblos in particularly, it's understanding how maintaining a healthy mind, body, and spirit, and the environment pure, that sustains us. And it all begins from the left side of the slide, where we honor the gifts that have come from the Creator. This is what has been given to our ancestors for generations, and has been passed on each generation since. It's the land, the language, the way of life, family, natural resources, etc., which all collectively and also individually itself, they create the core values of love, respect, compassion, balance, empathy. And those themselves sometimes get forgotten by us as we move around in our daily lives, especially when we live in two worlds like I do. Yes, I'm from Zuni, but I also live here in Albuquerque because that's the place that gives me opportunities so that I could take the benefits back home to care for my family and my relatives. And sometimes being in those two worlds, I sometimes become forgetful about some of the core values that are inherent and have been shared with me from generation to generation. Spirituality is something that if I were home, it would sort of be a daily thing for me that I wouldn't have to think about practicing. Here in the city, I've got other things on my mind that sometimes I forget to rise before the sun does to say my morning prayers to offer some cornmeal. It's only when I come to work that I realize that I missed a step in the beginning of my day and I have to go out and do it. But what happens then is we have traditional calendars that are not like the usual Western calendars. And these calendars, particularly for the Zuni Pueblo, have big significance during the winter and summertime. We have our two ceremonies that begin in the wintertime. We just finished that. And it's a year-long process that certain selected individuals as well as certain families who are willing to take on that task embracing. And they follow the practices and the requirements of the responsibilities of that. And they go through the spring and then they come to the summer, and that's where we have our rain dances as a way of acknowledging the creator and all the ancestors that have gone before for all the gifts that they've given us to reinforce the core values that they have infused in us that we should be mindful of on every day, to say that, yes, we are honoring you during this time of the year as we begin the planting season to start the cycle of life for the plants that we depend on as the calendar moves into the fall where we harvest, and then back to winter when we sort of acknowledge the end of their cycle of life as plants and animals and other beings, including some of our own people who have succumbed to various illnesses or other circumstances who aren't with us anymore. But then we begin anew. We plant songs and prayers, and then we begin again. So the cycle, it's a validation and reaffirmation of the core values in our way of life. For other individuals or other groups, here's just what I've been able to learn from my colleagues here at SENA and other individuals who are part of this call about a different way of looking at a calendar from the Navajo perspective. You know, Navajos talk about the creation stories of primordial ancestors such as first man, first woman, and changing woman, who played an important part in the creation of their world, but also in the health and well-being of their people and their communities. And it's their belief too that their ancestors and other companions emerged from a series of different worlds that are underneath the current world that we occupy. And it's their beliefs and attitudes that health and wellness are an integral part of their beliefs and spirituality. So prior to the European contact, the Navajos were a vibrant group of people, different bands that roamed freely within their ancestral boundaries. And, you know, if you look at this, you see these various mountains, which are named in the Dene language, which actually are what Navajos reference as their ancestral boundaries, but it's not limited only to that. Just like the Pueblos, there's additional land beyond that that also are part of the ancestral places that they visited, just as the Pueblos have visited other places here in the Southwest. So one of the newest things that I found to be a very important when we talk about cultural humility is this Harvard implicit association test. And I'm hope that at least some of you have given it a try to see how well you do in this association test. It was developed in 1998 by Harvard University to address the needs for a valid measure of implicit bias in research. And since it has been used widely by individuals to assess the strengths of their subconscious associations between different objects, which psychologists believe lead to implicit bias. The Harvard IAT is a sociological tool designed to measure implicit biases or attitudes that people may have unconsciously. It assesses the strength of associations between concepts such as race, gender, or age, and evaluations, positive or negative, that individuals may hold. The test typically involves quick categorizing words and images, and the reaction times are used to infer implicit biases. So basically, in simplistic terms, the IAT aims to reveal hidden biases that individuals may not be aware of, providing insights into automatic associations that can influence behavior. It's important to note that the IAT has faced some criticism. I took this about maybe 6 years ago, and then about a year later tried to go back in and do the Native American test, and it was no longer part of the website in itself. And so there was, just a question of why did they take it off? And I guess it's because, as I stated, it faced some criticism, and so some of its results are not always definitive indicators of personal beliefs or behaviors, so that they took it off. And I don't know if they revamped it again, but it's back on again, as I checked it just last week on it. So the reason I brought this up was because I was very intrigued by this article that I came across, where Dr. Zeskolt, Spence, McDermott, and Stone did this healthcare provider's negative impact of attitudes and stereotypes of American Indians based on the IAT. And some of the language that I was able to read from their article, it says there was some evidence of negative implicit attitudes towards American Indians, verifying previous research findings of healthcare professionals holding negative implicit attitudes. And it was just not Native American Indians, but it also was pertinent to other patient groups such as African Americans, obese patients, and the LGBTQ, the disabled, etc. The other interesting finding was that it supported previous research to say that cultural competency and implicit bias training may reduce implicit biases. And lastly, those that participated, they said receiving training in cultural competency, they reported a slightly lower implicit prejudice than those who reported that they had not completed cultural competency training. And the full citation for this article is down on the bottom here. I will make sure that you guys get the slide set so that you can read the article in its entirety on your own. But I think what this article really reinforces is that the more us as care providers in any level in an institution such as UNM and at UNMH on the Health Sciences Center side, the more we know about ourselves and our biases and about our own cultural values, beliefs, and practices, the better we're able to engage with those that we want to care for or that we have some relationships with in a professional manner, or for those that want to come and seek our assistance based on what expertise or knowledge or training that we might have. So are there any questions up to this point?
Thank you, Norman. I just wanted to say thank you because it's like 1 minute left
Okay.
for your presentation. But is it possible for our allies to reach like competency and all of that, because there's so much there, or is that something that they're always going to have to strive for?
I think it's always something that they have to strive for. When you look at cultural competency and cultural proficiency in an institutional setting, there's a need for cultural competency, particularly for those that have had the academic training and have acquired the education to be in the different healthcare professions they are. When you go to a doctor, you want to make sure that they're competent in the profession when they say they're a doctor. So there's a need for cultural competency in that manner. Cultural proficiency is also necessary in a institute like UNM, and also especially the hospital, because you want your care provider to be proficient in not only the education, but the skills and practices that they are, especially those that are within the healthcare setting. It's different when you go into the various indigenous communities, the Native American communities, because I myself, I will never be culturally competent in my own culture and in my own community, nor will ever be cultural proficient in my own community's culture, because it's always evolving, it's always adapting. But as I stated earlier, having been displaced, I've lost that time to have actually been able to gain what I was supposed to have gained up to the point that I'm at now. So there's various individuals themselves who are younger than me, who are more proficient in the Kiva setting that I shared with. And so for me, 60 plus years old, I feel kind of embarrassed going asking a 30 or 40-year-old man, could you help me out? Because I'm not culturally proficient. I'm not culturally competent. So it just
Thank you.
is a matter of where it's used that it fits in. I hope that answers the question.
Yes, thank you. And I
You're more than welcome.
saw one hand up, just letting you know.
Okay.
Yeah, thanks, Doreen. I just wanted to let everybody know that this is scheduled to go till 4 p.m. And so we will end sooner if Norman's presentation ends and there are no more questions. So we're not ending at 3 p.m.
Oh, okay, thank you.
Sure, yeah, I did have one question, and it's about language and concepts of health and the way Native Americans conceptualize health versus the way we do define health in English. Are there barriers to the way Native Americans conceptualize and define health in
If you-
understanding it? The
Yeah,
way,
if I can hold off on answering that,
sure.
there's slides that are coming up that might be able to provide answers to that. Yes, Nikki.
Hello, Dean Collins would like to know, are there any tools to assess how well an institution engages in cultural humility?
I think it's just having part of what I've been engaged in here at UNM through Learning Central is the requirement to take implicit bias training as part of a leadership position. I know it's slated for those that are potentially on the selection committee or some sort of committee where you're looking at another individual's qualifications to be part of the institute, but that's one way that I know of. The other way is just ensuring that even in undergrad, we begin to teach the actual history of this country that we call the United States. And even further down into the high school and middle school, that we start talking about the actual history of America. Because a lot of the middle school, the high school kids, they don't get exposed to the actual history of America, which includes also those other groups that came to be part of the creation of America, like African Americans, the Hispanics, the Latino, Asian Americans. They're not part of the history as is being taught in the high school setting. It's not until they come to college where, you know, if they're lucky enough to go into a class that's provided by the Native American Studies department, that then they begin to really understand, okay, well, we do have some portion to the makeup of, you know, the historical aspect of the United States. Another way is just engaging with a lot of the Native professionals that are here at UNM, both on the South Campus and the North Campus, and getting to understand where they come from. Maybe having them create a little segment of their own community and what are their cultural values, beliefs, and what are their protocols. Because not all Pueblos abide by the same protocols when it comes to engaging maybe in just, you know, social settings. There's protocols also for what we call religious ceremonies and engagements. And I know the Rio Grande Pueblos have a lot of feast days, so there's a lot of protocols there. Zuni, which is greatly distant from the metropolitan, we don't have any feast days, so, but we do have very unique traditional dances that have strict protocols. So just learning where the diversity of your population is and having that opportunity to learn from them could be a beginning. And certainly seen as available to provide this cultural humility training based on who's requesting it. We tailor the cultural humility training based on which population we're presenting to. So I hope that answers the question. Mr. Banani?
Yeah,
Is it possible to stop sharing the screen for now, or do you have some more slides?
I have some more slides, but I can stop and then I can share again.
okay. Yeah, I was just gonna mention something. You know, I think it's interesting that with culture, in that first slide, I didn't see language in there. Language is a huge part of the Native culture because, as Norman indicated, you know, we have several tribes in the state of New Mexico, and we all have distinct different languages, even within the Pueblo, as well as within the Navajo tribe. We have the dialect is a little different depending on what part of the reservation you're from. But what I was going to say is that I think it's important when you engage with the people, the Native people that you're dealing with, to understand at least their background as far as where they're from. I guess just to give you a little example, most of the natives, Navajos, I should say, they rely on IHS. I don't know if you're familiar with IHS. If you're not, then probably familiarize yourself with it. And unfortunately, IHS, I don't want to say that they don't have a very good track record, but there are some stories to that. So there is again, the generational trauma, the historical trauma with that. It's the federal government provides that to the Native Americans. And for Navajo specifically, if they're not treatable at that Indian house hospital, they're actually flown here through what's called contract health. So they're either flown to UNM, Lovelace, whoever they contract with, and or other hospitals in the Southwest region. You know, and so when that happens, you get some of these patients that come. Language is a huge deal. So it is a huge deal because if they don't understand what you're talking about, or maybe some of the experiences they've had with IHS locally, it's going to become difficult when they come to UNM, to Lovelace, or other regional hospitals that are able to deal with whatever they're dealing with or coping with. So with that, language is a huge deal in terms of treatment, and just knowing, maybe just asking, you know, where are you from? That way, that it'll give you some idea as to understand, begin to understand a little bit of some of that cultural humility that comes along with that. You know, I myself, kind of like Norman, went through the placement program. So I don't know everything, but I do know enough to understand, you know, as far as my culture goes. For instance, with the seasons, you know, we had our New Year's in October. So it's different than the traditional New Year's that we celebrate as the rest of the country does. So, but there's always room for learning, and I'm always interested in learning. However, you know, we are disposable. I am available if anybody ever has any questions. You know, I'm with HSC, CTCS. So, but there's always room for learning. There's always room for understanding. I spent the time in South America, and I think Norman would understand what I mean by that. I was a missionary in South America, And it was always interesting when the Americans would come around. And it was interesting. They just didn't fit in. And the reasons why they didn't fit in, of course, is because they would always speak English. They would always think that they're still in America, but it was South America, not North America. But I did fit in somewhat, but not as uh, some way I blended in because I still looked indigenous, so not quite criollo, as they say down there. But that was interesting. So, it's always good to learn, to sit back, observe, understand a group of people or a different ethnic group. And in my case, I was fortunate enough to learn Spanish, the culture down there. So, and which really helped. Just a little insight. Thank you.
Randy, I just wanted to ask if you would give us a little bit more information about where you are in HS, Health Sciences, and maybe put some information in the chat about how people could follow up with you if they are interested. And thank you so much for your comments.
Thank you, Mr. Manali. Well, he's doing that. I just want to remind people that Dr. Bird put in a resource, guiding principles for researchers engaging with Native American communities in the chat. And so let me go back to my presentation, which I think will answer a lot of the questions that were brought up and some of the comments that Randy had. So before we move forward, one of the things that cultural humility requires is that sometimes you have to excavate the history of the people that you're engaging with, have to understand. For the American Indians, Alaska Natives, one of the big things is how there's been a progression in terms of land loss from 1492 all the way to potentially 2090. If you look at it prior to contact, the entire US was occupied. And I have to clarify, it's not owned. It was occupied in a reciprocal relationship with Mother Earth and all the other living entities that Mother Earth was able to provide for and cared for. But look at how much land has subsequently been taken away from Native Americans to what it is now here. Most of it is west of the Mississippi, centered mostly in the Southwest and some parts of Wyoming, Montana, Arkansas, a huge section down in Oklahoma. So, when you hear argument about, well, go back home, well, for Native Americans and Alaska Natives, we've always been home. As the first immigrant that came to this land that we occupied, and subsequent people that came in the federal rules, regulations, policies, ordinances, statutes that they created, where they created land as a commodity. And in doing so, they severed the intricate relationship that Native people had with the land. And so when I hear people say, well, go back home, even here in Albuquerque, I hear people telling other Native people to go back home. I look to say, why should they go home? Because they're already home. Even though Albuquerque is parceled and owned by various individual land owners, it's still homelands to a lot of the Pueblos, a lot of the Navajos, a lot of the Apaches, and a lot of the Southern American ethnic and minority groups. Because in my Pueblo's migration story, where we say our origins are from the fourth underworld, starting at the bottom of Ribbon Falls and Grand Canyon, moving up 4 levels to the level that we're at, there came a point in time where our people had to divide into 2 bands to find the center place that we currently reside in, which is the western side of New Mexico, way over here. My ancestors moved north and currently occupy what we call Zuni land. Well, the other band of ancestors, they moved south. How far south did they go? We don't know. So when I hear of people coming from Latin South America, I wonder, are those my relatives? Are those my ancestors? And so just imagine me, myself, sitting and listening to the news while the big, what is 16-foot steel barrier is being erected between US and Mexico and Southern America. And razor wire fences are being put up to limit the number of people that are crossing. I sit and I share tears because in our origin story, it says that at some point, the people that went south will come back north and we will reunite. Having those barriers erected has an impact on the potential for my tribe to reunite. So, it's just not to say that the reservation is my home, but the entire south portion of the United States, as well as South America, could potentially be my home base based on our origin stories. So here are the 2021 numbers. The 574 might have changed, but it's the policies that have been created that allows for some legal recognition of some of the tribes here in the United States through the Bureau of Indian Affairs. 40% are located in Alaska, the rest are in the lower 33 states. But unfortunately, 66 plus tribes are only state recognized. They don't get the benefits that the federally recognized tribes do. And as Mr. Benally's talking about the Indian Health Service, they don't get that benefit that the federally recognized tribes do. They might be able to get some state benefits if the state is open to allow those state tribes within their boundaries to also reap the benefits that their state residents do, but it's highly unlikely. Then there's this big thing about 70% of Native Americans living off the reservations. And you'll see why here in a bit. So here's sort of a compilation of the policies that have impacted American Indians and Alaska Natives since contact. When Columbus came, I think they threw out the word discovery quite a bit. But the question has always been, how can you discover something that was already occupied? So I think there's some fallacy into those words. But then policy was created to use manifest destiny and the doctrine of discovery as a way of encroaching that perpetuate the land loss, cultural loss, even the extinction of some of the tribes that occupied from east to west, north to south, what is now called United States. But the biggest thing that the new arrivals brought was an onslaught of diseases that, the native populations weren't immune to. And that in itself is a travesty. It's kind of some of the policies that the federal government has included as part of their dealings with native nations, using blankets that were infused with the smallpox disease. Adding alcohol as part of the bartering system so that, native people who have never been subjected to such large amounts of alcohol are taken advantage of because they're not in their right personage when they're making these dealings. So all these policies in the earlier part, having to do with mostly eradication, trying to get rid of them. And in the 80s, a lot of that policy was, okay, if we couldn't get rid of the entirety in terms of the community and the people, let's take segments of that community. And that's where the boarding schools come into play, where they take the children away as a way to quash the language, to quash the culture. And then if that didn't work, then they started to remove Indians from what they occupied in terms of land, move them to other places that were at that point not inhabitable. When you talk about the Black Hills of Montana. But if that's didn't work out, then of course, there's points in our history where entire tribes were massacred because they weren't willing to abide or assimilate to the dominant culture. And then, of course, as I talked, land being one of the biggest resources that was gifted by the Creator, that in itself was taken away, and allotments of land were created so that all the Native Americans, Alaska Natives, could actually be in a position to own some land, but at the same time, they have to agree to become farmers. But what good is that for a tribe who subsisted on hunting, on gathering, and had no skills to be farmers? So it's learning new things through learning different traits. And then from 1900s to the present, there's been sort of a change to try to allow some self-governance to take in place, and some acknowledgement about some of the treaty provisions that were agreed to, one of them being the Indian Health Service, created in 1955. But as Randy said, it's always a guessing game for Native people when it comes to June. When your health facility has such a limited budget that they can't take care of everybody. We all know that we can't get sick in June because that's when the contract dollars are no longer available in your home service unit. And then the other thing too is you cannot take those contract dollars to another service unit, meaning I belong to the Zuni service unit back home in Zuni. I cannot seek services here at the Albuquerque service unit and expect Zuni to pay for it. I have to establish residency here in Albuquerque, relinquishing my membership with the Zuni service unit. And if I do, there's no guarantee that the Albuquerque service unit will pick me up and pay for the healthcare needs that I require in my medical care. So what do? I play this game that I live yearly here in Albuquerque, but I go back home periodically to my service unit and get my primary care of diabetes and vision and dental so that I can still get the services I need, but limited. If I need more specialized service, it's out of pocket. Because Zuni knows that I'm not a full resident back on my reservation. If I were to abide by that requirement, I would be in a situation that I never knew I was in when I was a child. My parents didn't finish the 8th grade. My mom was a homemaker. My dad was a medicine man. They both didn't have full-time jobs. They subsisted on what we could grow and what we could care for in terms of livestock. And I never knew that I was poor until I got, as Randy said, to the placement program, living with an affluent family. So if I relinquish my position here and go back home because my health care and my health condition requires it, I'll be back in that position of being poor. And as the only income earner for my family, it not only impacts me, but it impacts my family as well as my community. So those are the games that natives play when it comes to Indian Health Service. The other thing is Indian Health Service is funded at the lowest of all other departments. The Bureau of Prison gets 3 times the annual funding that IHS does. So as a governor, there were 2 things that I used to say because of the historical nature of the US and other foreign countries. If I could, I would declare war on the United States. And people said, well, you're preposterous. Why would you want to do that? I said, look at the history of the US. When they go to war against a foreign country, they bomb the heck out of them. But after the war is over, what did they do? They spend billions to reestablish those communities, those countries that they just declared and had a war with. The other thing that I would do is I would erect a tall chain link fence with barbed wire around the exterior boundaries of my reservations and call it a prison. And people would say, well, why would you want to do that? My answer was because the Bureau of Prison gets 3 times federal dollars than Indian Health Service to do healthcare service in my community. You know, those are just some realities that we sometimes don't talk about, but are there that, as Mr. Benally said, you have to be aware of, you have to be cognizant. So when a patient gets flown from their hometown of other Ganado, Saley, Chinle, here to Albuquerque, not only is language an issue, but it's also a financial burden for the family that come to care and to provide some support for that individual. Because as Native Americans, when one of us gets sick, they don't go by themselves. We go in droves. You see us in the waiting rooms, taking turns going in to the room that our relative is in, if not to speak with them, but just to sit and hold their hand or just to be in presence, because that's showing support. That's the closeness that we have as Native people when it comes to not only individual health, but family as well as communal health. So the funding that is needed for that group to be here, lodging, food, transportation, other needs, is huge. And it comes to be out of pocket because IHS or no other organization will pay for those. And those are things that as care providers, we have to be cognizant about. So just sort of wrapping up on the historical aspect of it, you know, these are some of the terms that come out when you collapse all the federal policies.
Norman,
Exterminate, yes,
I just want to give you a 30 minutes heads up, and we want to leave a little room for Q&A. Thank you.
yeah, I'm almost done. So it's talking about extermination, all the way to expulsion, segregation, and a lot of fusion. So when you talk about the 70% that live in metropolitan areas, it's within this area of fusion and assimilation that created the populations of native people in urban settings. When you have individuals given an opportunity to move off the reservation into the metropolitan area for work, that takes a lot of people off. When you talk about the potential of missionaries asking families like Randy's and mine to send our kids off to get a better education away from the reservation, that creates a void. BIA reservations, they're not on reservations, they're off reservation. So it creates these voids of people living on the reservation and adds to that 70%. But as we grow older, we realize that sometimes our communities aren't the best place to work at because employment opportunities, economic opportunities are not as great as it is in larger metropolitan areas. Education is not there. So we have to move if we want to be a benefit to our families and communities. We take that chance to move to gain opportunities in itself. So here's sort of a population density from the Urban Indian Health Institute of where most of the native populations reside. There's a large portion here in the Southwest, Oklahoma, as I said, and also up in the Northwest coast and up in the West Coast portion of this country. So when you look at all of those that I've said in terms of land, removal, language loss, sometimes cultural loss, boarding schools, IHS, federal policies, you look at how that impacts the social determinants of health for individuals here. And a lot of that is based on age, sex, and the constitutional factors of what certain federal programs provide for individuals. And so it becomes an individual lifestyle factor. But then also you got to consider what is the social and community networks that are available within a community. Are there support groups for people who need resources with elder care, child care? Are there resources for veterans that have come back after being in war and have disabilities? Do we have different programs that deal with suicide, that deal with alcoholism and other chronic diseases? But beyond that, we also have to look at the social, economic, cultural, and environmental conditions that natives live within. Is there adequate housing? I think the pandemic really highlighted the fact that even in one particular nation, Navajo, it showcased that there was not adequate housing. There was inadequate water and sanitation. The living conditions were very poor. Working conditions were very poor. And so the ability to work as well as to gain an education was impacted, let alone healthcare services were not there, to deal with this big impact of COVID. And subsequently, we're still struggling with the impact of the influenza and other viruses that are now impacting tribal communities. So there's also potential barriers that Native Americans have to face in health and well-being. Limitations in terms of their physical being. Are they able to go to their appointments? How does spirituality come into play if they're very spiritual individuals? Are there limitations that they can do in terms of working with Western methods of treatment? What resources are available, especially the specialized care? Pediatrics, geriatrics sometimes aren't there. Surgeries not there. And sometimes access to care is difficult. You look at this picture of this policeman trying to go through a muddy road. Sometimes roads become impassable, especially this time of the year where inclement weather really comes into play. But then also we have to realize that there's a lot of assumptions that go around. I think Randy and I are sort of one of those individuals that maybe it was not our choice, but we grew up in a different type of a spiritual or religious environment. And whether we continue to practice it or not is our individual choice. You know, I was lucky I was not like Randy, I didn't go on a mission. They wanted me to go to Japan, but I ran away from Salt Lake City before that happened, so yay. And then the other barrier that as healthcare providers we have to be cognizant about is our own selves. As the Dalai Lama said, if you feel burnt out in a setting, if you feel demoralized or exhausted, it is best for the sake of everyone to withdraw and restore yourself. I can't say that enough. You're not good if you're feeling the pressure to continue to do your job. Your mind is not into it. Your body's not into it. Your spirit is not into it. And then there's the potential to do harm. So take care of yourself first. And then just quickly, here are the numbers within New Mexico. 11% of our population identify as American Indian and Alaska Natives. And in the Bernalillo County, that's 6.3%. And here in Albuquerque itself, there's 25,317 individuals that identified themselves as American Indians or Alaska Natives, but they're not all from the Pueblos tribes. Pueblos, Apaches, or Navajo, they represent a whole host of other tribes. So here's where those that reside and call New Mexico home live. These are the reservations, primarily in the northwest section are the Pueblos. We have the larger Navajo Nation occupying 3 states, Utah, Arizona primarily, and then New Mexico. And then we have 3 Apache tribes, Jicarilla, Mescalero, and then a little dot down here, which is the Fort Sill Apache. And interestingly enough, the Ute Mountain Ute actually has land holdings here with just north of the Jicarilla. And so they do get benefits from the state themselves. But look at how much other native communities are within Arizona that don't abide by these dotted lines. It's just like air and water. Those 2 elements don't know boundaries. And us natives also don't know boundaries when it comes to relationships, and it also comes to health. Some of these people who might be on the western fringes of Arizona come all the way to New Mexico to get health care. I mean, that's their choice. They choose to do that. I've had some, when I was still working in Zuni at the health facility, I had some people that were up in the northern portions of Arizona, Navajo Nation, bypass all of these other health facilities in the Navajo Nation, come all the way to the Zuni service unit to get their primary care. And why? It's because it was customer service, they said. That was their words. They get better customer service here than they did back in their hometown. So, you know, we are migratory people in a way when it comes to health. Keep that in mind. So there's the historical aspect of New Mexico and the different tribes. I think a lot of people know about the Pueblo Revolt that occurred in 1680 after multiple years of abuse by the Spanish and the Catholic faith. The Pueblos revolted and were able to push the Spanish out for at least 10 years before they came back. There was also wars that were happening between the Apaches and the Navajos. The Apaches were basically scouts for the westward trails that were being made by all of these horse-drawn wagons as they migrated to California for gold mines and other opportunities. But at some point, frictions came about where, the Apaches were seen as enemies. And so they got rounded up and they got sent to Fort Sumner, just 300 miles of Albuquerque, to be interred and to try to become civilized. Well, it was also at the same time that the Navajos, because of the federal policies and through the directions given to Kit Carlson to round up all the Navajos to take him from their home bases near and around Gallup all the way to that same place, Fort Sumner, to have them be encamped there to try to have them become civilized. But unfortunately, Fort Sumner is not a place to create a good base for farming because of the salinity of its environment. So after a while, both were released. The Navajo history is that this long walk took a lot of people, especially when the forced walk happened during the wintertime. A lot of the elderly and the children succumbed to the elements and they died before they got to Fort Sumner. And then when they were released in 1866, a lot of the people came back, but they had no transportation. And so that's part of the history that we all need to be aware of, and that leads to mistrust when it comes to creating relationships with these groups of people. Just some general beliefs, and here's a differing core values. I think the biggest thing that I'm experiencing right now is a time expansiveness. I could talk for like 2 days, but here in this academic institute, I'm time bound. I probably have less than 9 minutes now, so I better abide by that. Other things, we're passive people. We're not aggressive. We're not very, in terms of communication style, sometimes it's not nonverbal, where in, the Western style, it's a lot of verbal. We rely on a lot of oral traditions or oral stories. In the Western, it's written prescribed methods of learning and teaching. And some popular things to keep in mind in terms of health beliefs. Elders are revered. And so when we talk about Alzheimer's, dementia, and other associate diseases, that's a big concern. We learn through various prayer songs. Sometimes when we get to ask of what is health, it's just not the physical. It's a holistic way of being. I like the word that the Navajos use, ojo, which is the wholeness of being in balance, not just in your physical, but it's also your body, your mind, your emotions, your spirituality. All of those have to be in balance for somebody to be hojo. And also understand that sometimes health beliefs mean that certain foods are restricted during ceremonies. Sometimes medication is restricted during ceremonies. And so in comparison, this is what the popular American culture is. Youth is revered. They're direct and specific when it comes to engagement sometimes. And Western medicine is primarily of healing, where in the American, it's a lot of potential of not only being in balance, but trying to be preventative in a way. This is some etiquette. We dress conservatively, behavioral, and in our behavior. Sometimes handshaking can be seen as characteristic nature of somebody not being trustful. It really is not. Handshaking is reserved for close friends and families. A simple nod of the head is generally acceptable. I find it that when I clasp my hands and I nod, that's a way for me to show reverence to people that I engage with. Our high content communication is, as I said, stories. analogies that we use. So when you engage in a patient-provider relationship, don't always be one directed. Be mindful that, sometimes you might want to be asking them questions that, they can share some other insights with. Simple questions like, what do you think caused your health problem? And as I said, we don't reply in a direct manner. We might actually tell a story of why we think that this is the reason why our health is a concern now. And it might include other beliefs that we have maybe neglected to remember by maybe disrespecting another living entity. And those kind of like taboos, for me, maybe I didn't remember and I stepped on a stink bug. Well, for my pueblo, stink bugs are related to lightning. And so if I have some sort of a health problem that is related to that stink bug, I can find some sort of comfort by engaging the medicine people who know how to put me in balance and to make amends to the stink bug that I might have stepped on. So just keeping in mind, asking them, the most important thing is to understand how severe do they think this sickness is from their mindset. As I said, in terms of holistic health, what does it mean in terms of their emotions, in terms of their spirituality, in terms of their mental capacity? The other thing is, what does it mean to their family, especially if they're of a standing within a keyword or a clan? What does it mean for the continuance of the clan's and practices and teachings and different ceremonies? Last thing, engaging in research. We need your research, because if you look at this from the Indian Health Service, disease of the heart, malignant neoplasia, accidents, unintentional injuries, and car accidents are part of this. And of course, diabetes. Cancer is now becoming one of those biggest things in my pueblo that people are becoming concerned about. But we need your research to answer the questions of why it's happening. But if you look at it on this side, you look at in terms of where are American Indians, Alaska Natives in comparison to all the other races, look at how the ratios are. 2.5 for accident and injuries, 3.2 for diabetes. But my goodness, look at that, alcohol related 6.6. And this began from having alcohol introduced as part of the treaty process, as well as how it has this relationship to chronic liver disease and cirrhosis, 4.6. And so be patient with us if you come to tribal communities. Don't expect that you'll get an answer immediately. Respect tribal protocol. If the answer is no, accept that no. If you're willing to work to allow leadership to be part of the research, even the community to be part of the research development, engage them, and let them also be part of the research process, as well as the research analysis, and also the opportunity to determine whether what's discovered and published is allowed to be shared outside the community. There's too many examples of where researchers came and they published without tribal approval, and it caused a lot of harm. And then the last thing is understand and respect cultural beliefs, especially when it comes to collecting specimens, genetic testings, and certain conditions. We as Native people that believe that every aspect of our personages is ours, and that we have a right that upon our life's journey's end, that it also goes with us. So if it means that a participant gave approval to use their specimens while they were alive, and you find out that they unfortunately have now transitioned to the next stage of their life's journey, that those specimens be considered to be destroyed or returned back to the family so that it could reunite with the individual. So, and the last thing is just report back to the community. We'd like to know what you discovered, whether it's bad or good. And we'd like to have approval on whether it's shared with anybody else. And so that's my contact info. If you'd like to have more conversations with me, go grab a cup of coffee or something, let me know. I love learning from everybody. So, Dr. Andres?
Thank you, Norman. That was fantastic. I think that there must be at least 50 or 60 questions that we could all ask. I want to get everybody's feedback. We do need to end at 4 to respect people's time. One of the tenets of these convenings is that we're learning what we don't know. There's a lot of stuff we just don't know. So we want to hold another session. We'd like to hear from you if you want to participate in another session that just involves talking, because that is really the way we exchange ideas and learn from each other. So put in the chat, having another session, that would be great. And then we have like 7 minutes. Does anybody have like a really key question that they want to ask? I'm going to take a risk and ask this question. The committee wants to know what else it should do. That list could be very long, but if you recommended one other thing that this committee should explore, what might that be, Norman?
Well, I think American Indians, Alaska Natives are only one sector of the population that utilizes UNM and UNM hospital and other services. I certainly would like to hear sort of the same presentation from all the other racial, ethnic, and minority groups. Even those that are from the LGBTQ community, including the disabled people. Sometimes we don't keep those groups in mind when we create policies or we think about programs that could benefit the larger population, because sometimes they have unique needs that aren't discussed in the larger setting. And so that would be great to learn. But then also, if there's the possibility of any one of all of you who are in the professional ranks to maybe bring out an article that relates to your experience about engaging in meaningful relationships with different groups. And let's have, sort of like a journal club, talk about it. How does it relate to us? How did it impact us when we're reading it? And what can we do to maybe use some of what was written into our daily learning? And also, if we're fortunate enough to be mentors or we're teachers, how we can use it to those that, follow our footsteps.
Those
I hope
are
that answers the question.
It does. Those are great ideas. I put in the chat our other 3 convenings that cover the other groups that Norman mentioned. And yes, we do need to cover a few other groups that we're not covering in 2024, and I love the Journal Club. I'm gonna ask Chairman Berlin Joseph to close us out, and then maybe you guys want to mention the book club as well.
Hi, everyone. Sorry, not Grace, it's me. Zoom technical difficulty. So thankfully I was able to to pivot. So sorry, Dr. Bird, I see you have your hand raised. Did you want to make a quick comment or a question?
Sure, a quick comment. Given the slide where Norman talked about the borders and lack of borders that we have as Indigenous people, I just want to put this out there regarding land acknowledgement. I think the university has several land acknowledgements, but I think it's limiting when they only acknowledge, Sandia Pueblo, because that's like a very small group of people, but there's so many others that call this place home. I just wanted to say that. And also bring community in. I really hope that maybe this sparks some interest with people from the university to engage more with our tribes. And when we have feast days, come out. They're open to the public, because that's the best way you're going to learn about Native Americans, is actually being in their homes or their home villages, and then seeing them at their best. Because we also oftentimes in the medical setting, we see them when they have a health problem or, mental health issues. But when you go to the communities themselves, then you get to see what are their strengths that you could draw on. But there's so much to learn by actually visiting the communities or bringing them into our College of Population Health setting. Thank you.
Oh,
And
yeah, thank you for those.
If I might add to what Dr. Bird said, is when you come into any tribal community, leave your camera, leave your recording devices at home. Infuse all of that experiences through your eyes, through your ears, and through your mouth, because you're gonna eat a lot of the food that is being prepared, but experience it through all the senses that you have, and leave it at that, because that's one of the protocols. Thank you.
Grace,
Thank you.
oh, can you guys quickly mention the book club and our first book that we're reading? Is that a Grace?
Yes, we'll be starting off reading and discussing Red Nation Rising, From Border Town Violence to Native Liberation by Nick Estes, who is now at University of Minnesota, and other authors at University of New Mexico.
Great, thanks.
Okay, so with that, if we can all give a warm round of applause, both virtually, or you can do it, as you choose, to our speakers today. Thank you for the opportunity to listen, to learn. I think as we move forward, it's just as a committee and as a college, we want to take heed to what our esteemed speakers spoke today, especially around cultural humility, cultural practices, as we move forward in our college and move and transition to a college of public health. I think it's very important that we really apply these tools that we learned about today. So again, thank you so much for your time. Special thanks to you, Norman, and thank you to everyone who attended today and contributed. We appreciate your time. Thank you.
Thank you so much.
Thank you, everybody.